Hey folks, this is Dr. Ken Sharlin here, and I'd like to provide to you about a procedure that is called a lumbar puncture, or some people call it a spinal tap. Now, I'm a neurologist, medical doctor, and I've been in practice doing this type of procedure since the early 1990s. So suffice it to say, I've probably done thousands of these procedures. And I do call them spinal fluid examinations or lumbar punctures. In the language that I speak as a neurologist, I don't tend to use the term spinal tap, although some people still utilize that term. I think part of the reason is, besides the terms that I use being more medically accurate, the term spinal tap sort of has a connotation that brings a lot of fear and worry to folks. And so I just avoid that term altogether. This is a very routine test. And in a nutshell, it's performed to measure certain aspects of spinal fluid, whether that's the pressure that the spinal fluid is under, or certain chemistries related to spinal fluid, or whether or not there's infection or other what we call biomarkers, and I'll explain that in a minute, present in the spinal fluid. Essentially, the possibilities are pretty limitless, just like all the different blood tests that you can have done. Many of those tests can be done on spinal fluid, but sometimes the testing is more specific when spinal fluid is examined. Now, when I was taught to perform this test, I was told that at any given moment in time, there are about 140 cubic centimeters or milliliters of spinal fluid present within the spinal and skull cavity. This is a fluid that's produced at the center of the brain in a tissue called the choroid plexus. And you can find big cavities full of spinal fluid in the two main areas of the brain called the lateral ventricles. But this spinal fluid is going to track down through channels and aqueducts in the brain, ultimately to bathe the spinal cord and the brain, so that the spinal cord and brain essentially almost float inside the skull and the spinal fluid. Now, this spinal fluid really is a tissue of the body. It is biologically active. And it turns out, for example, that in the arena of regenerative medicine and stem cell medicine, that spinal fluid actually communicates with stem cells that have started their journey from your bone marrow and found their way into the spinal fluid, and activates those cells to express what are called neural elements. But I want to go way upstream before a discussion of all of that, and just go over a spinal fluid examination and what we can learn from spinal fluid. Again, at any moment in time, you have about 140 milliliters of spinal fluid, which would be maybe about 1 liter, which is 1,000 milliliters. So I think I'm getting that right, hopefully. So you have about a tenth of a liter, roughly, more than a tenth, 1.5, divide 1,000 by 150 at any rate, present, and you're constantly making more. So the very small amount of fluid that's actually removed is going to be replaced. Now, we do tell our patients to arrive at the clinic well hydrated for this procedure. Being hydrated is always better. If you're going to have blood drawn, if you're going to have spinal fluid drawn, it really makes the blood flow or the spinal fluid flow much easier for your doctor or the person performing the procedure. So arrive hydrated and try to arrive relaxed. Really, I always tell my patients this is only slightly more complicated than having blood drawn, and by and large, it's not any more uncomfortable. So the person arrives to our clinic. We do not resort to fluoroscopy, which is kind of like live X-ray guidance to do the lumbar puncture. It really isn't necessary. I'm going to lean over and grab a model, and you'll have a better idea what I'm talking about. I'm going to pick it up. So here is the human little model of the human pelvic bone. And when you're laying on your side, which is what you're going to do during the spinal fluid test, this is kind of the position of your hip bones. And what I'm going to do is put my hand on the top of your hip bone. This is the iliac crest. And I'm going to feel down, and I can actually feel these little spinous processes and the space between the spinous process. And we call that the L4-5 interspace. And so to reassure you, the spinal cord has already ended. There is no possibility of piercing the spinal cord with a properly performed lumbar puncture. There are nerves that are descending down in that canal below the level of the spinal cord. They're called the cauda equina, but they kind of just move out of the way. And really, in the worst case scenario, you might feel a little tickle, but again, we're going to numb you up anyways. It's just not going to happen when this is performed properly. So again, you come into the clinic, you're well hydrated, you're relaxed, because this is going to be a really easy procedure at Sharlin Health and Neurology. I'm going to have you laying on your side. The nurse is on the other side of the exam table, so you can see the nurse. She's going to help you bring your knees up. Ultimately, you're going to have your knees as tight against your chest as possible. Here you are, kind of this way. Again, your knees are tight against your chest as possible. And I put my hands on that hip bone here. I'm going to kind of come directly down, and I'm going to feel for that space between the bones that are going to open up because you brought your knees up toward your chest. So that opens up this space. That's why we want your knees high up, okay? Because if your knees are low, then we can't get the needle through that space, but if the knees are high, it opens up that space, and this is a really easy procedure. Okay, so I'm going to put on some gloves. Initially, I just put on some clean gloves. This is a sterile procedure, but initially, I'm just going to put clean latex gloves on, just like this. And again, you're laying on your side, and we're talking a little bit because I like my patients. I want everybody to be relaxed, right? And I have a procedure table next to me where I have this tray. Now, I actually just did a lumbar puncture, so I've got some tubes with spinal fluid that I'm going to show you even. So the patient's laying on their side. I put my hand on the hip bone. I've decided exactly where I'm going to be numbing up and then inserting the needle. And then I'm going to use a iodine-based solution called betadine to actually scrub your skin to remove the surface bacteria and minimize the likelihood of infection. Now, if you happen to be iodine sensitive, we can always use something called ChloraPrep, which is alcohol-based rather than iodine-based. But in either case, it's fine. We clean off the skin. We also use some sterile drapes to kind of frame out that area. So these are just paper towels, basically, that are sterile. I'm going to tuck one in under you. I'm going to tuck one kind of in your pant waist, which is pulled down maybe an inch or two. You're not going to be exposed really for the procedure, but I want to have a nice square open spot where I'm going to do the procedure, and everything else is covered by a sterile drape. I do have another drape kind of on top of you that has a little sticky on it, so it can kind of drape over the front towards your belly, and everything's covered. So I've cleaned you up, and the next thing I'm going to do is I'm going to numb you up. And this is actually 1% lidocaine, and the kits, I call this a kit, comes with some syringes, and I actually use a very small needle. You probably can't even see this, a 30 gauge needle, and I'm going to numb up just a little area of skin, just underneath the skin. We call it a bleb. So it's just a subcutaneous numbing. Honestly, that's probably the part that hurts the most, and it's pretty minimal, right? So I've just numbed up the surface of the skin, and then I'm going to take a little bit bigger syringe. So here's a little bigger syringe. I'm going to fill that syringe with lidocaine. See, I'm going to go all the way up to the top, right? And then with my hand on your back, what I'm going to do is very slowly infiltrate that area that the spinal needle is going to go into very slowly with lidocaine, right? So you're going to feel some pressure, pressure, pressure. If I need to get some more lidocaine, I take the needle out, get a little more lidocaine, I go back in. And again, we carry plenty of lidocaine in the clinic. My nurse always has a bottle in her pocket. So I'm going to make sure that you are completely numbed up. You're not going to feel this, okay? This is no big deal. And the second time I put that needle in, you're already numbed up. So I'm just going to go a little bit deeper, right? So I'm numb, 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 numb. Maybe I put about 3 to 5, no more than 5, but generally like 3 milliliters at the most. It's a very, very small amount of lidocaine, but it's plenty to numb you up. So now we've got you all numbed up, and then I'm gonna, and by the way, I've put sterile gloves on at this point, not just my clean gloves. I've got sterile gloves on, right? Because this whole tray is sterile, and so we want to be super clean. So I've numbed you up, and then I'm going to give it a couple minutes for that numbing medicine to really fully kick in. So I have these tubes. This is where the spinal fluid is collected, and I'm just opening the tops of the tubes and I'm laying them out on my tray, and we're chatting again. I'm going to give it a little time for the lidocaine to fully kick in. And I'm also telling my nurse, okay, make sure he or she has, let's say your name happens to be Jane. Make sure Jane's knees are as close to her chest if she can make them. And ladies generally are a little more flexible than the guys, but either way, we're going to work with you, okay? All right, so you're numbed up and your knees are up by your chest, so you're really not going to feel anything more. We're going to go back to about that L4-5 or L3-4 inner space, and then I'm going to insert a needle, okay? And here is a spinal fluid needle. Now, I know it looks long, but sometimes we only generally have to be about halfway in. And again, you're not going to feel this, okay? You're not feeling it. So we're just having a nice conversation. How was your weekend? Wasn't it beautiful this weekend? What did you do? That kind of thing. How's your grandkids, right? So I'm inserting the needle, inserting the needle, inserting the needle. And generally, because I'm very experienced at this, I can kind of feel that I'm in the right place, right? There's not a lot of guesswork involved. Okay, so I'm in the right place, and then look what happens. I take the center part out of this needle, and guess what? Spinal fluid starts coming out. Now, spinal fluid, I'm going to cut to the chase. Healthy spinal fluid looks clear. The only time this is going to look yellow or bloody is 2 situations. Okay, we're not going to see yellow spinal fluid in my clinic because that's like somebody who has acute spinal meningitis, and that's a medical emergency. We don't do lumbar punctures in the clinic for that kind of medical emergency. That's an emergency room hospital situation, okay? Now, if somebody has a lot of blood in their spinal fluid, one of 2 things has happened. If they had something called an arachnoid hemorrhage or an aneurysm burst, again, that's a medical emergency. There's a very serious problem. People present with what they call the worst headache of their life, and you never, ever see that in the neurology clinic. You see that in the emergency room or the hospital, okay? Now, we are going through tissue, your tissues, right? And occasionally we'll get a little bit of blood in the spinal fluid, a little pink tinge, and that's not unusual. In my hands, most of the time that does not happen, but it's not unusual, and that quickly clears. And we'll always know that that was just a little bit of what we call a traumatic tap. It's not dangerous. In fact, it's sometimes actually sort of helpful, but it's no problem. And usually we don't even have that. Okay, so what's happened? So the needle is in there. I pull that little center stylet out, and the spinal fluid is flowing. Now, I might be interested in the pressure of the spinal fluid. So I'm actually going to stick this in on the end of the needle, and then there's actually a little stopcock. And so I'm going to kind of put it together. I'll show you. And I'm not going to do the whole thing here, but you'll get a pretty good idea. Okay. And this fits on the stopcock. Let's see. Nope, wrong piece. There you go. Okay. So this actually has centimeters on it. And I am able to measure what we call the opening pressure of the spinal fluid. So there are some times when that's going to be really important. We especially see young to middle-aged women, can occur in guys, but more often in women who have a condition called pseudotumor cerebri or idiopathic intracranial hypertension. And that's a condition where they overproduce spinal fluid, and there's opening pressure is higher than it should be, and that's bad because it can put pressure on the nerves that connect your eyeballs to your brain, your optic nerves, and actually can cause vision loss. In the cases where we're suspecting elevated pressure, we can measure that pressure. Normal pressure is like 12 to 21, 22 centimeters of water. I always say 22 to 25 is kind of a gray area. We start to get in the 26 and above, and believe me, I've seen it. That's elevated pressure, and we need to lower the pressure. And we can do that a couple ways. We'll take off extra spinal fluid, and then we put them on medicine to help lower the pressure. And there's even things we can do beyond that. But that's a little digression. So then we're going to collect some spinal fluid. So here's a tube with spinal fluid. How many people watching this video thought that spinal fluid would look like blood or look yellow or look, kind of like pus material or something like that? Let's hope it does not look like that. It looks like water, folks. Spinal fluid looks like water. So here is a person that I evaluated for Alzheimer's disease. And that's a really big thing I want to talk with you about today. And I've collected 5 tubes of fluid. Now, they're not completely full. So altogether, I have 2, 4, another 3, that's 7, 8, 10 cc's of spinal fluid. Don't forget, again, person has 140 cc's of spinal fluid. We're just getting a small amount of spinal fluid, and they're going to probably within a few hours, they've replaced the spinal fluid that we drew off. So this is not a big deal at all, right? So this is going to be tested for some different things. There's some things we always test for. I'm going to look at the white blood cells, which are your immune system cells, red blood cells, which of course come from your blood vessels. We shouldn't see too many red blood cells, but as a general rule of thumb, for every 1 white blood cell, there can be up to 10,000 red blood cells. So remember I said if I occasionally get a little blood in the spinal fluid, I'll know if that is just from trauma or there's perhaps something going on, that you have a huge number of white blood cells relative to the number of red cells that suggests that we've got an inflammatory process going on, right? Now, occasionally I see this, but even in multiple sclerosis, which is another very common reason to do spinal fluid tests, we don't see generally that many white blood cells. If a person with MS has a ton of white blood cells in their spinal fluid, they don't have MS, they have something else going on. So I'm looking at the cells, I'm looking at the protein level and glucose. That's especially important when you have a bacterial infection, for example. Bacteria like to gobble up the glucose or sugar, and so low sugars are seen in bacterial infections. Again, that's going to be meningitis, and by and large, we don't see that in the neurology clinic. Protein can be high in some cases of infection, some inflammatory disorders, and even in some neurodegenerative disorders like ALS, where the findings will be non-specific, meaning you can't make a diagnosis of Lou Gehrig's disease from spinal fluid, but if you do have elevated protein, that is a supportive finding. I then reserve 1 tube for microbiology. So I am going to look for bacteria, including the TB bacteria we call Mycobacteria. And then I'm also going to look for fungus. So the pathologists who receive the spinal fluid, they're going to be doing stains and look at the fluid under the microscope, but then they're also going to be doing some culturing of that spinal fluid. And again, usually in the outpatient neurology clinic, we don't see any of that. That's not the main reason we're doing spinal fluid testing in outpatient neurology. Inpatient, yes. And by the way, if we need to test the spinal fluid for Lyme disease, we can also do that. Many things we can test for, right? Okay, now, Alzheimer's disease and MS. We need a 4th and a 5th tube. In MS, we're testing for immune globulins that are in your spinal fluid that are present in a disproportion to immune globulins that we see in the blood. And those are called oligoclonal bands. There are other tests that can be done on the spinal fluid for MS, like myelin basic protein, but actually a lot of these tests have kind of gone by the wayside. If you go over the 2017 revised McDonald criteria for multiple sclerosis, you'll find that the main biomarker at this time that is used commercially are oligoclonal bands. So to do that, we need your spinal fluid and we need a little tube of blood because, again, we're comparing these immune globulins in your spinal fluid with your immune globulins in your blood. Alzheimer's disease. And Alzheimer's disease, this is really a condition where we've had the most advancements in what are called biomarkers. And these are changes that we can identify in the fluid that are specific for a given disease. Now, there is a protein called amyloid protein or beta amyloid 42 that is very common in Alzheimer's disease. It's actually, in a sense, an inflammatory marker. So anytime you might have some inflammatory threat to your brain and to your body, amyloid levels can go up. They can go up even if you're sleep deprived, for example. But they tend to go up, and then when you catch up on your sleep, they'll go back down. In the case of Alzheimer's disease, this amyloid forms an insoluble protein that builds up higher and higher and higher. And eventually, you also start breaking down the nerve cells themselves. And as those nerve cells break down, there's the release of a protein called tau, T-A-U, that's made from the transport machinery of the nerve cell that takes stuff, I'll just put it that way, from the nerve cell body down to the far end of the cell called the axon. That's called a microtubule assembly. It may be a little too sciencey for you guys, but tau, T-A-U, is another protein found in the spinal fluid or found in the brains of people with Alzheimer's disease, and we can measure it in the spinal fluid, and this actually represents nerve cell injury. So when we're looking to do a spinal fluid test on someone with memory loss that's progressive, who we think could be evolving early Alzheimer's disease, and by the way, the changes that occur in the brain that become Alzheimer's disease have their start 10 to 20 years before the onset of symptoms related to Alzheimer's disease. So we can actually make the diagnosis of early evolving Alzheimer's disease in the preclinical state before the person ever has memory loss, before they have memory loss. So we can say that they have the biochemical changes in the spinal fluid. And that's really important because we are going to be seeing in the next 3 or 4 months potentially, and then over the next few years, a variety of treatments that are aimed in particular at both the preclinical state, meaning before your symptoms show up, or the early state before things get really bad, okay? We want to catch people early, and this includes a compound that's being developed by Biogen Corporation called aducanumab. Lilly has one in the pipeline as well. I'm sure there will be others. These are the two most advanced in terms of the research and closest to becoming commercially available, especially the Biogen product. So we want to identify the changes before they really become a problem, because again, if you think about that tau protein, that's nerve cell destruction, and no one wants nerve cell destruction. So we want to know, before the house starts to burn to the ground, is this Alzheimer's disease, and we can stop it. It's like calling in the fire department and put out a little fire rather than, put out the final cinders of a house that's actually burned completely to the ground. So we don't want that, right? So what we do for Alzheimer's disease is we actually get 5 tubes. The kit actually comes with 4 tubes, but we get a 5th tube. And there's a couple of reasons for that. On tube number 4 that comes in the kit, we're going to measure something called your amyloid beta 42:40 ratio. And the 42:40 ratio is this amyloid protein that's different amino acid lengths. Amino acids make up this protein called amyloid protein. They're the building blocks of this protein, right? And it turns out that some amyloid is 40 amino acids long and some is 42. But the amyloid beta 42 is the one that's associated with Alzheimer's disease. So we can measure the amount of 40 and 42, and the lab will calculate for us what's called the 42:40 ratio. And the lower your 42:40 ratio, the greater the probability of developing Alzheimer's disease. Now, notice I said probability. I didn't say you have Alzheimer's disease yet. This measures risk, and that's good, but it's not specific enough. So with tube 5 that comes from a commercial lab, has a little different makeup to the tube. It looks like this. You wouldn't know it was different. We know it's different. We're going to draw an extra tube with a couple of cc's of spinal fluid, and we're going to be able to send that to a lab that's going to measure tau protein, total tau, what's called phosphorylated tau, and amyloid levels. And they're going to create a graph for us using a calculation called the amyloid tau index. And they're going to plot that on a graph against the amount of phosphorylated tau. And if your result on this graph falls above a certain cutoff point, that tells us that the findings are consistent with Alzheimer's disease. So what I've done today is I've walked you through the basic procedure. In my office, we're talking 10 minutes, maybe 10, 15 minutes at the most. Painless procedure, which I collect the fluid, the needle is removed, no bleeding by and large, or minimal bleeding. And you're going to straighten your legs. We're going to kind of massage the area a little bit. I'm going to remove those sterile drapes. My nurse is going to come around. She's going to put a Band-Aid on your back. That is how much you need, just a Band-Aid. So we did this procedure for you. We're going to tell you to hydrate, rest up, kick back on the sofa today, catch up on Netflix or your favorite binge program or the movies you wanted to see. We don't want you lifting, bearing down, etc. Hydrate well. And 9 out of 10 people, no problem whatsoever. Now I'm going to close with this. There are a very small percentage of people who develop something called a post-lumbar puncture headache or post-LP headache. These are not fun. They are not dangerous. They feel bad, but they are not dangerous and they are treatable. And the way you would know if you had a post-LP headache is that you're okay when you're laying down, but when you stand up, you get this pounding headache because it's essentially a low pressure headache and the brain settles down and there's some stretching of that meningeal layer around the brain. So initially this can be treated with caffeine. I recently did have that occur with one of my patients. I called in a medicine that's known as Caffergot, has a little ergotamine type medicine in it. That was very helpful. But a lot of people end up getting a procedure called a blood patch. Now here at Sharlin Health and Neurology, we'd like to help you not have to go to the emergency room for a blood patch. So in those rare infrequent instances where you have a post-LP headache, we can send you to a local clinic that we work with on a regular basis, and they have a fluoroscope. They have an anesthesiologist on staff. They draw a little blood out of your arm. They inject it into that space where you had the lumbar puncture, and the headache is instantaneously gone. Okay? So I want to reassure you that this is uncommon, that aside from a post-LP headache, I never have a problem with a lumbar puncture. I've never seen significant bleeding. No one has ever died. No one has ever paralyzed. If you've heard this, I'm going to tell you is wrong. It is wrong information. These are easy procedures that we do in the clinic every day, or almost every day. Very frequently. I've done thousands of them. They go well. They're super easy. I don't want you to worry. So if you need a lumbar puncture, if you're worried about MS, if you're worried about elevated spinal fluid pressure, if you're worried that you might be evolving Alzheimer's disease, or your doctor is, I want you to come to me. We're going to take care of you. You don't need x-ray guidance. That's super expensive. It exposes you to unnecessary x-rays with radiation. Come to me. We're going to take care of you. I hope that was super helpful. Again, I want to reassure you, this is very easy. It's a relatively inexpensive test. It's covered by insurance. If you need the procedure, you're definitely in good hands. So wonderful to visit with you today. Let me know if you have any questions. I'll sign off now.